Everyone, welcome. Today we are going to be presenting Her Health, Her Voice. This workshop focuses on women's health advocacy by exploring how gender bias within healthcare systems contributes to delayed diagnosis, dismissal of symptoms, and inequitable care. Participants will gain practical tools to navigate healthcare systems, communicate concerns effectively, and advocate for themselves and others in ways that promote equitable access, participation, and well-being.
And before we start our workshop, we'd like to do a land acknowledgement. We acknowledge that Western University is located on the traditional territories of the Anishinaabe, Haudenosaunee, Lemnapawak, and Chinooktun nations, on lands connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. This land continues to be home to diverse Indigenous peoples, whom we recognize as contemporary stewards of the land and vital contributors of our society.
So just as some general housekeeping, please keep your microphone muted when you're not speaking to help minimize background noise. And this session is being recorded, but the recording will be paused during any reflection or sharing portions to foster privacy. And you're welcome to turn your camera on if you feel comfortable. And you can use the chat to share questions or comments during the workshop, but we'll also have a dedicated Q&A at the end. This workshop has been created in partnership with CFUW, who is a nonpartisan, voluntary, self-funded organization with 6,700 members and 90 clubs located in every province across Canada. Since its founding in 1919, CFUW has worked to improve the status of women and to promote human rights, public education, social justice, and peace.
So, moving on, we'll just give a quick introduction about ourselves. So, my name is Sally, and I'm from Windsor, Ontario. I finished my undergrad at the University of Windsor with my Bachelor's of Science in Kinesiology. And I'm currently in my second year studying my Master's in Occupational Therapy here at Western University.
My name is Claudia, and I'm from Mississauga, Ontario. I received my Bachelor of Science at Western University in Kinesiology, and I'm also currently a second year student in occupational therapy at Western.
Hi everyone, my name is Linda and I'm from Markham, Ontario, and I did my undergrad in human biology at University of Toronto, and I'm also currently in my second year of occupational therapy.
Hi everyone, I'm Nicole and I'm from Fort Frances, Ontario. I did my kinesiology degree at University of Manitoba in Winnipeg, and I'm also currently a second year occupational therapy student at Western.
Hi everyone, my name is Sherry and I'm an international student from China. I did my undergrad in health sciences in Western University and I'm currently in the second year studying occupational therapy at Western as well. So before we get started, I want to briefly walk through the goals of today's workshop. First, we aim to increase the awareness of gender bias and systemic inequities in women's healthcare, particularly how these patterns show up through pain dismissal, delayed diagnosis, and unequal treatment. Second, this workshop is about building practical self-advocacy skills. We'll focus on tools you can actually use to navigate healthcare systems, communicate concerns more clearly, and feel more confident during medical encounters. Third, we want to empower women to engage in both individual and collective advocacy. This means not only advocating for your own care, but also recognizing how shared experiences can drive broader change toward more equitable and respectful healthcare. To support ongoing learning and action, participants will also receive a Women's Health Advocacy Toolkit, evidence-informed infographics, a services and resources handout, and pain management and health condition advocacy materials that you can continue to use beyond today's session.
So, to set the scene, women around the world experience a range of health conditions that are frequently dismissed, misdiagnosed, or diagnosed far too late. So, today we'll briefly explore why conditions that disproportionately affect women are often delayed or overlooked, and why these delays have real and lasting consequences. Across these conditions, research has shown that a consistent pattern where women frequently experience years of symptoms before receiving a diagnosis, that is, if they receive one at all. These delays are not just frustrating, but they also contribute to worsening physical symptoms, emotional distress, reduced trust in healthcare systems, as well as missed opportunities for early intervention. Studies have shown that clinical knowledge gaps, inconsistent diagnostic pathways, and systemic inequities play a major role. So now let's briefly look at how this shows up across four common conditions. The first is polycystic ovary syndrome, also known as PCOS. PCOS is a complex endocrine condition affecting women of reproductive age and is commonly associated with irregular menstrual cycles, elevated androgen levels, which can show up as being acne or excess hair growth, and metabolic complications. Globally, it affects an estimated 8 to 13% of women of reproductive age. Despite being common, PCOS is frequently missed or diagnosed late. Large surveys show that about one-third of women wait up more than 2 years for a diagnosis and often see multiple healthcare providers along the way. Fewer than 40% report being satisfied with the information they received at diagnosis. This can happen for several reasons, including PCOS symptoms that vary widely, menstrual irregularities that are often dismissed as normal, and clinicians may focus on fertility while overlooking metabolic or long-term health impacts. The consequences of delayed diagnosis include poor symptom control, increased anxiety about fertility and health, and lower satisfaction with care. The next condition we have is endometriosis. This is a chronic inflammatory condition in which tissue similar to the uterine lining grows outside of the uterus. It can cause severe pelvic pain, painful periods or intercourse, gastrointestinal symptoms, and sometimes infertility. Estimates suggest that it affects about 5 to 10% of women of reproductive age. Endometriosis is known for extreme diagnostic delays. Systematic reviews have shown that a median delay of up to 7 years in some populations. Pain is often normalized, symptoms overlap with gastrointestinal or urinary conditions, and diagnosis has historically relied on surgical or blood work confirmation. Referral delays and fragmented care further prolong the process. Delayed diagnosis is also linked to worsening pain, reduced quality of life, emotional distress, and significant impacts on work, school, and social participation. The next condition is uterine fibroids. This is benign tumors of the uterus and are common during reproductive years. While many fibroids are asymptomatic, others can cause heavy menstrual bleeding, pelvic pressure, anemia, and fertility complications. Studies have found major disparities in diagnosis and care, and in US cohort studies, Black women have fibroid diagnosis rates more than 3 times higher than white women, with Hispanic and Asian women also experiencing elevated rates. At the same time, symptom documentation and patient education prior to diagnosis vary widely. Delayed recognition can lead to severe anemia, reduced quality of life, and fewer opportunities to explore non-surgical treatment options before major procedures become necessary. And lastly, we have pelvic inflammatory disease, also known as PID. So PID is an infection and inflammation of the upper reproductive tract, often caused by untreated sexually transmitted infections. Symptoms may include pelvic pain, fevers, abdominal discharge, and pain during intercourse, but presentation can vary widely. PID is often missed because symptoms overlap with other abdominal or pelvic conditions. Pelvic exams may be limited, and social stigma can discourage open conversations about sexual health. When PID is not identified early, the consequences can be severe, including infertility, chronic pelvic pain, ectopic pregnancies, and long-term reproductive damage.
So before we begin, I'd like to invite everyone to pause for a moment and reflect. Think about a time when you or someone close to you experienced a healthcare encounter that felt inequitable, dismissive, or unfair. This could be a moment where your concerns weren't taken seriously, where you felt rushed, unheard, or treated differently because of your gender, background, or circumstances. Take a moment to notice how that experience felt, not just physically, but emotionally and functionally. Did it affect your trust in healthcare? Did it change how or when you sought care afterwards? These experiences are not isolated. They are not personal failures. They are shaped by systems, structures, and patterns that we're here to talk about today. As we move through this workshop, I invite you to keep that experience in mind because understanding and addressing healthcare inequities begins with acknowledging the lived experiences behind them. So we'll take a moment to just sit and reflect for a moment, and I will prompt to move on when we are finished. We could move on to the research and evidence. So to understand why women's pain is so often dismissed, we looked at three key research articles. Together, they show us that this isn't about individual doctors making bad choices. It's about a pattern that shows up again and again across healthcare systems. So the first study by Chen et al. 2008 examined nearly 1,000 adults who came to the emergency department with acute abdominal pain, which is one of the most common and severe reasons people seek emergency care. This study focused on non-traumatic pain, situations where clinicians rely heavily on what the patient reports, not just what they can see on imaging or exams. The findings were striking. Although women and men reported nearly identical pain scores, indicating comparable pain intensity, women were significantly less likely to receive any pain medication. When treatment was provided, women were also far less likely to receive opioid analgesia and experience longer delays in care, waiting on average more than 15 minutes longer than men to receive pain relief. The researchers then asked an important question. Could this difference be explained by something else, like age, diagnosis, race, triage level, or even the gender of the physician? After controlling for all of these factors, the disparity still remained. Women were still 13 to 25% less likely to receive opioid analgesia than men. This is especially important because it tells us that women weren't being treated differently because their pain was less severe or because their conditions was less serious. They were treated differently because they were women. Even in urgent, time-sensitive medical situations, women's pain was taken less seriously, treated less aggressively, and addressed more slowly. This study provides some of the clearest clinical evidence that pain dismissal in women is measurable, persistent, and built into how care is delivered. Moving on to the second study, it builds on the first by expanding the scale. So instead of hundreds of patients, these researchers examined over 21,000 emergency departments visits across 2 different countries, allowing the researchers to see whether this pattern was consistent across healthcare systems, and it was. The findings were both consistent and concerning. Women were less likely to receive pain medication of any kind, including both opioid and non-opioid treatments. They were also were less likely to have their pain scores documented at all, which matters because what isn't documented is less likely going to be treated. What makes this study especially powerful is that the researchers didn't stop at identifying the disparity. They asked why it happened. To answer that, they conducted experimental studies where clinicians were given identical patient cases, with the only difference being the patient's gender. Even when all the medical information was nearly the same, clinicians consistently rated women's pain as less intense and less urgent than men's. This pattern reflects what the authors call a gender pain exaggeration bias, an unconscious belief that women's pain is more likely to be exaggerated or emotionally driven. Importantly, this bias wasn't present regardless of the clinician's gender, showing that it's not about individual intent, but about deeply embedded assumptions in healthcare. Together, these findings show that women's pain dismissal is not random. It's predictable, widespread, and driven by bias that operates below conscious awareness. So moving on to the third article by Hoffman and Tarzan helps us understand the deeper reason behind everything we just discussed. The authors don't focus on statistics or emergency department data. Instead, they asked the fundamental question. Why are women's pain and symptoms so often dismissed in the first place? They explain that women experience what's called a credibility gap in healthcare. Pain is subjective by nature, which means clinicians have to rely on what the patients say. But culturally and historically, women's pain have been viewed as more emotional, exaggerated, or psychologically driven, while men's pain is more often seen as physical, legitimate, and requiring action. This puts women in a double bind. If a woman clearly and persistently advocates for herself, she may be labeled as dramatic, anxious, or difficult. But if she downplays her symptoms or stays quiet, her pain is more likely to be minimized or ignored. Either way, she risks not being taken seriously. Over time, this pattern has real consequences. Many women learn through repeated experiences that seeking care may not lead to relief or validation. As a result, they delay the appointments, avoid emergency care, or stop seeking help altogether, even when symptoms worsen. Hoffman and Tarzian argue that this is not just a clinical problem, it's an ethical one, because it violates principles of fairness, respect, and justice in healthcare. This article helps us see that pain dismissal isn't just about individual encounters, it's about long-standing beliefs that shape whose voices are trusted and whose pain is believed. So moving on, I wanted to show you guys infographic. It's designed primarily from a patient and community perspective. It brings together everything we discussed so far and translates it into practical, usable tools. So you'll notice that the focus here is on preparation, communication, and advocacy. The goal is to help women feel more equipped before a healthcare appointment or emergency visit, whether that means knowing how to prepare notes in advance, how to describe your symptoms clearly and functionally, or how to respond if concerns are minimized. And there's also a second infographic. It focuses on the evidence behind why these advocacy tools are necessary in the first place. So it really hones in those three articles that I've just discussed before. And it highlights the research demonstrating the gender pain credibility gap, showing that women's pain is consistently taken less seriously than men's. And this infographic summarizes key findings from large-scale and clinical studies showing that women were less likely to receive the pain medications as discussed before. And there is in the bottom corner a QR code where you can access a OneDrive where all these resources that we presented will be available to you even after this workshop.
Okay, so next I will share some statistics and evidence comparing endometriosis that we touched a little bit before and versus erectile dysfunction, highlighting the gap between these two conditions. So both endometriosis and erectile dysfunction are common sexual and reproductive health conditions. Endometriosis is estimated to affect about 10% of women of reproductive age in Canada, which is about 1 million people. Globally, estimated prevalence differs widely, with some areas and regions up to 70%. Also, the prevalence among gender-diverse people with a uterus remains largely unknown due to the limited data. Similarly, erectile dysfunction affects a larger number of men, with prevalence increasing significantly with age and different in severity. While both conditions are common, they differ greatly in how quickly symptoms are recognized and addressed within the healthcare system. One of the most severe and life-impacting symptoms of endometriosis is pain. This may include chronic pelvic pain, painful menstrual periods, pain during sexual activity, and even during urination or bowel movements. Endometriosis can also cause gastrointestinal symptoms, excessive menstrual bleeding, fatigue, and infertility. Many individuals receive diagnosis when seeking medical care for infertility. Overall, endometriosis is a chronic condition that makes people deconditioned and affects daily functioning, overall health, and quality of life. In contrast, erectile dysfunction primarily affects men during sexual activity and generally doesn't impact daily functioning to the same extent. Diagnosis of endometriosis is significantly delayed. One major reason is that its symptoms overlap with many other conditions. For example, pelvic pain or bowel symptom may be misdiagnosed as gastrointestinal issues, reducing the likelihood of correct diagnosis. Low awareness also plays a role. Symptoms are often dismissed as normal menstrual cramps or natural part of aging, making people less likely to seek medical care or encouraged by others to do so. Patient-related delay refers to the time between the symptom onset and a patient's first attempt to seek medical care. For endometriosis, this delay is 3.1 years on average. One important thing is that this is not about blaming patients, but about identifying systemic gaps and raising public awareness so that solutions can be developed. To better manage our health, it is essential to understand what is typical for our bodies and to recognize when something feels different. For example, menstrual cramps can be normal, but pain that cannot be managed with over-the-counter OTC medication may indicate the need for professional treatment. Preparing before medical appointments can also support more sufficient communication and more effective care. Later this hour, we will share resources on how to self-advocate within the healthcare system. Finally, for those who are working or will work in the healthcare system, creating a safe and validating environment is critical. Even though providing diagnosis or medical treatment is not within our scope of practice, acknowledging clients' experiences and advocating for them can make a meaningful difference. History shows us that change is always possible. For example, postpartum depression was once dismissed as a personality flaw or an inability to be a good mother. But today, it is widely recognized and formally included in the DSM, the Guide for the Mental Health Diagnosis. This shift did not happen overnight, but resulted from years of patients speaking out and healthcare professionals listening and responding. Endometriosis has a significant impact on people's daily life, and it can create challenges in education, work, and social participation. Research shows that adolescents with endometriosis symptoms are 10 times more likely to miss school. Chronic pain can make it difficult to concentrate on meaningful activities, including studying, working, and leisure. People with endometriosis may also face increased challenges in maintaining relationships. Persistent fatigue reduces available energy for social interaction, and ongoing pain can limit participation in daily routines and valid roles and responsibilities. We, as occupational therapy students, can play a role in supporting individuals with endometriosis through pain and fatigue management. This may include education on energy conservation strategies, such as scheduled breaks, breathing techniques, and adaptive body positioning to help manage symptoms. Pain flare-ups can be unpredictable and severe, so we can work with clients to develop coping strategies alongside medical treatment provided by physicians. Symptoms that are chronic and difficult to manage may contribute to mental health challenges, including stress, anxiety, and frustration. These challenges are often linked to difficulties in taking responsibilities in life roles, such as a student, employee, caregiver, or partner. In comparison, the impact of erectile dysfunction is generally more specific and localized, primarily affecting sexual function. This may lead to challenges in intimate relationships and increased mental stress, but it typically doesn't affect daily functioning across as many life domains as endometriosis. And this slide highlights how conditions that primarily affect women continue to receive far less investment. despite their high prevalence and significant impact on daily functioning and quality of life. In 2020, only 5% of global health research funding was dedicated to women's health. Within that limit share, 4% went to women's cancers, and only 1% covered all other women's health conditions combined, including endometriosis. Although progress has been made, it remains limited. In 2021, the Canadian government committed $45 million over 3 years to support care, information, and services related to endometriosis. In 2023, another $36 million was dedicated for the following 3 years. And let's compare this to erectile dysfunction. Between 2019 and 2033, companies focusing on erectile dysfunction received 6 times more funding than those focusing on endometriosis. So that is 1.24 billion versus only 44 million. However, it is important to note that all these comparisons are not intended to rank or dismiss suffering across sexes and genders. Highlighting the challenges faced by one population doesn't invalidate the experience of another. These comparisons aim to emphasize that endometriosis and all other women's health conditions deserve greater awareness, research resources, and healthcare attention, as they affect or will affect nearly half of the global population. So here is another infographic summarizing the key information and statistics we just discussed. So feel free to scan a QR code at the corner to access additional resources and to learn more.
Before we talk about strategies, I want to start by naming something important. Many women are taught, either directly or indirectly, to not question healthcare professionals. Today, we're going to reframe that. Advocating for yourself is not being difficult or disrespectful. It's a fundamental part of receiving care and ethical healthcare. Patient rights exist to protect you and to support shared decision-making. Knowing your right gives you language and confidence when something doesn't feel right. You have the right to clear, understandable information, not rushed explanations or medical jargon. You have the right to ask questions until you understand. You have the right to consent to or refuse treatment. You have the right to request a second opinion or referral. You have the right to access your medical records at any time, and you have the right to bring a support person to appointments. If speaking up feels hard, that makes sense. Healthcare systems can feel rushed, hierarchical, and intimidating. The goal isn't perfection, it's progress. And some examples of things you could say are, I need a bit more information before deciding, or I don't feel comfortable with this plan yet, or can we talk about alternative options, or I'd like this documented in my chart. Now that we've talked about the evidence showing the healthcare disparities women face and learning about your rights as a patient in a healthcare setting, we want to focus on what you can do to navigate these systems more effectively. So, preparing before an appointment or emergency visit. Preparation helps ensure that your concerns are clearly communicated and documented. Before an appointment or emergency visit, it can be helpful to write down your main symptoms, when they started, how often they occur, and what makes them better or worse. It's also important to note how your symptoms affect your daily life. Things like work or school, sleep, caring for others, or your ability to move or concentrate. This information is clinically relevant. You're not over-preparing, you're giving providers the information that they need to understand the real impact of what you're experiencing. Describing symptoms more clearly and effectively. Research shows that women's pain is more likely to be minimized, especially when symptoms are described in vague terms. Using clear, specific, and functional language can help counter that bias. For example, instead of just saying, I'm in a lot of pain, you might say that this pain has lasted for 3 months, or the pain is severe enough that I can't work, sleep, or care for myself. Describing how symptoms affect your ability to function helps shift the conversation from whether your pain is quote unquote real to how it's impacting your life. And talking about pain ratings, if you're asked to rate your pain on a scale, be honest and consistent. And if it helps, explain what that number means for you. For example, you could say a 7 for me means that I can't function normally. This helps providers understand your experience rather than relying on assumptions. And knowing when to ask for more support. You have the right to request a second opinion, a referral to a specialist, follow-up care, or even a different provider if one is available. You can also bring a support person, written notes, or previous medical records. Saying, I'd feel more comfortable with another opinion, or I'd like a referral to explore this further. It's not being difficult, it's participating in your care. If your concerns feel minimized, it's okay to say things like, I'm concerned this isn't fully being addressed, or the pain is affecting my daily functioning and I need help managing it. If symptoms are attributed to stress and anxiety, you can respond by saying, I'm open to discussing stress, but I'd also like to rule out any other physical causes. Or can we explore both physical and mental health explanations? And if no plan is offered, it's reasonable to ask, what are the next steps if this continues? Or can this be documented in my chart? Documentation matters. Advocacy doesn't end when an appointment ends. Following up and documenting your experiences are powerful and often overlooked forms of self-advocacy. Documentation creates a paper trail. It can protect you, support continuity of care, and reduce the risk of concerns being dismissed over time. You're allowed to keep records of your own health. Written follow-up helps reinforce that your concerns are ongoing and valid, and documentation shifts advocacy from one moment to an ongoing process. So, what are some things to document? You can write down the dates of your appointments, names and roles of providers, symptoms and how they impact your daily life, advice or treatment plans that were given, and what helped and what didn't help. And you can use some different follow-up scripts, such as, I'm following up because my symptoms have not improved, or I was told to expect a referral and I wanted to check in on the status, or since our last appointment, my symptoms have changed, or I'd like clarification on the next steps we discussed. Persistence is an important part of self-advocacy.
So here we have included 3 handouts that summarize and reinforce the information presented earlier. The first 2 handouts on the left offer practical advice on how to approach conversations about pain management, including tips for initiating those discussions and strategies to use if your concerns are being dismissed or minimized. The handout on the right features a curated list of sample questions organized by subheading that you can use to ask your doctor. Recognizing the vulnerability that comes with seeking medical care and attention, the inherent power imbalance that can exist in healthcare settings, we've also created these questions to help spark ideas and build confidence. Our goal is to support you in advocating for yourself, communicating your needs more effectively, and seeking clear, meaningful answers to your concerns.
So, what are the implications and calls to action for occupational therapy and healthcare professionals? As OT students and future petitioners, it's important to recognize that gender bias in healthcare is not just a social issue, it's a clinical and ethical issue that directly affects occupational participation, access to care, and quality of life. Occupational therapy competency frameworks emphasize professional responsibility, ethical practice, and equity. When women's symptoms are dismissed or misdiagnosed, this results in a failure of ethical care. As OTs, we are accountable not only for what we do, but for what we allow to go unchallenged within healthcare systems. Client-centered practice is foundational to occupational therapy. Women's self-reported pain and symptom experiences are not secondary or subjective add-ons. They are valid clinical evidence. When these experiences are dismissed, it undermines assessment accuracy, goal setting, and intervention planning, and it ultimately restricts participation in meaningful occupations. OTs also have a clear role in advocacy. This extends beyond individual client encounters, and we are expected to engage in a system-level thinking, such as advocating within interprofessional teams, contributing to policy-informed practice, and challenging documentation and assessment practices that disadvantage women, particularly when symptoms are invisible or diagnostically complex. Collaboration is another key competency. OTs and healthcare professionals are uniquely positioned to translate pain into functional impact. explaining how symptoms affect work, caregiving, rest, mobility, and identity. By articulating these occupational consequences, we can help ensure women's needs are recognized and addressed within interprofessional decision making. Importantly, while empowering women to self advocate is valuable, OTs and healthcare professionals must not shift responsibility onto our clients. Equitable care should not depend on how articulate, persistent, or prepared a woman is. Our role is to support advocacy while also working to change the systems that make advocacy necessary in the first place. Ultimately, addressing gender bias in healthcare is an occupational justice issue. Gender intersects with race, disability, socioeconomic status, and immigration status to further restrict access and participation. As OTs and healthcare professionals, we are called to recognize these intersecting inequities and to actively work towards healthcare systems that are equitable, respectful, and enabling for all women.
Now I'm going to give a brief overview of the types of local resources available in the London and Middlesex area that support women's health, safety, and advocacy. These resources you can access for yourself and share with others. You'll have the resources available with the QR code on the slide. And there's also another handout on the next slide that will show with QR codes for each resource listed. This overview of resources is to help you understand what kinds of support exist and when you might use them. One part of health advocacy is knowing where to go for help, not just in emergencies, but when you feel dismissed, unsure, or stuck navigating the system. You may not need all of these resources, but knowing that they exist can also make a big difference. The first resource listed is CFUW London, our community partner for this project. They advocate for women's health equity, education, and policy, and can be a helpful resource after this workshop if you have further questions, you want to stay engaged in advocacy, or you're looking for additional support. Following is the Healthcare and Women's Health Services section. These services support things like sexual and reproductive health, primary care, and specialized women's health needs. What's important here is that many of these services are free, low cost, or designed for people who face barriers like not having a family doctor, being a newcomer, or feeling dismissed in traditional healthcare settings. Next are the mental health, trauma, and crisis supports. Organizations like ANOVA, CMHA Middlesex, and Parkwood Institute support women experiencing violence, emotional distress, or mental health challenges. These resources recognize that health isn't just physical, it goes beyond that into feeling safe, supported, and believed, which are essential to overall well-being. You don't have to be in crisis to reach out, and many of these services also help with navigating the system when it feels overwhelming. The fourth section is advocacy, legal, and system navigation. This includes organizations such as London Abuse Women's Centre and Legal Aid Ontario. These organizations help women navigate systems that can feel intimidating or unfair, such as healthcare, legal, or social services. These are important resources to access because many women are not heard or taken seriously, especially when dealing with abuse, housing issues, or facing discrimination within healthcare. The following section is cultural specific and inclusive supports. Some resources are designed to provide culturally safe and inclusive care, including Adlosa Family Healing Services, the London Cross-Cultural Learner Center, the Muslim Resource Center, and the Regional HIV/AIDS Connection. These organizations recognize that women's experiences of healthcare are shaped by culture, identity, and systemic inequities. Finally is the resource navigation section. This is helpful if you're unsure where to start when accessing resources, as it can be very overwhelming. So if you're ever unsure where to start, accessing 211 Ontario is a very helpful step. You can call or search online and they'll help you connect to a local service with health or social services based on your needs. And if you're French speaking, you can access FemAid's resources as they do the same thing as 211 Ontario, but in French. On this slide, you'll see the same resources that I talked about, but with the QR codes for quick access, which is included in the workshop materials that you can also use and access from the QR code. The overall idea of these resources is so that you know where to look when you or someone you know needs support or when you want to advocate for your health.
As we begin to wrap up, I want to highlight one final resource that brings everything that we've talked about today together. We've covered a lot: knowing your rights, how to prepare for appointments, what to do during visits, how to follow up, how to document your care, and resources that you can use. That's a lot of information, and you're not expected to remember it all. That's why we created an advocacy toolkit. You can access it by scanning this QR code, or there'll also be one at the end of the workshop. And this toolkit includes clear information about your rights as a patient, step-by-step guidance for what to do before, during, and after healthcare appointments, practical checklists, advocacy scripts, and links to additional resources. It's all written down so you can return to it whenever you need, whether that's before an appointment, after a visit, or when something just doesn't feel right. You're welcome to save it, share it, or use it at your own pace. This toolkit is here to support you beyond today's session.
So at this point of the workshop, we want to invite you all into a short interactive activity focused on reflection and advocacy. So we've created an online pledge board where you can make a personal or a collective commitment related to women's health advocacy. This pledge board is completely anonymous. No names, emails, or identifying information are collected, and no one will know who wrote what. Your pledge can be small or big, and it could relate to advocating for yourself, supporting someone else, challenging dismissive language, or continuing to learn about gender inequities in healthcare. Advocacy doesn't always look like policy change or public action. Sometimes it looks like speaking up at an appointment, supporting a friend, or believing someone's pain when they share it. So we'd like to invite you to take a moment to reflect on what stood out to you today and then write a short pledge that feels realistic and meaningful to you. So I'll give you guys all a couple of seconds to just scan the QR code, which will lead you to the pledge board. And then we'll also put the link in the chat for easy access.
So before we close today's workshop, we really appreciate your feedback. We created a short anonymous feedback survey to help us understand what worked well, what could be improved, and how this workshop can continue to grow and support women's health advocacy. So this feedback serves two important purposes. It helps us refine and improve the content. It supports CFUW London in continuing and strengthening this work for future community groups. And it also allows us as OT students to reflect critically on what we can do better in future advocacy and education initiatives. So I'll give you guys a quick couple minutes to scan the QR code, as well as just take your time to do the feedback survey. Workshop. And we now like to invite you to ask any questions. If you have any questions, feel free to stay back as well. And we mentioned the QR code a lot of times during this workshop, but this is the final last showcase of the QR code if you want to access these resources. I really want to thank everyone for participating today and joining our workshop. Have a great evening and hope to see you in the future, OT students.